Thank you, David. And to give a counterpoint, we're going to have Maya Guglin, who's going to be arguing against use of cardiogenic shock in cardiac arrest staging.
Good morning. Thank you for the opportunity to once again try to defend the indefensible statement. It sounds like it's becoming my particular niche at this meeting. But Dave, thank you for the nice segue, the challenge to separate cardiac arrest and cardiogenic shock, because you said that they are like two strands of the DNA. So that's exactly what I will try to do, to separate these two entities. As a community, we quickly came to realization that not all cardiogenic shocks are created equal. We separately analyze characteristics and outcomes in cardiogenic shock due to acute myocardial infarction or due to heart failure, de novo or acute and chronic. So it's probably time for us to come to realization that not all cardiac arrests were created equal either. Our data from a couple of years ago from University of Kentucky, we retrospectively analyzed the structure of our in-hospital cardiac arrests. I was stunned when I saw this data. Basically, only 1/3 of cardiac arrests are determined by acute reversible conditions, combined cardiac and medical, for example, like hypokalemia. While 1/5 of all cardiac arrests requiring chest compressions and so on come from patients with sepsis, and another 1/5 occurs in patients who have known terminal disease, like liver cirrhosis or advanced cancer, but they're full cord, and everybody dies through cardiac arrests. So if their heart stops, they undergo CPR and the full spectrum of measures to restart their heart. Even if we are successful in restarting their heart, their survival is dismal. So from the same data, our data from several years ago, patients with sepsis, 70% survive initial cord, but only 10% survive to hospital discharge. Out of chronic conditions, people who undergo in-hospital cardiac arrest and get resuscitated, 70% survive the episode of the arrest, but only less than 10% survive to discharge. And only in acute reversible conditions, again, this is not even purely cardiac, it is cardiac and medical combined, there is a reasonable survival to discharge. Why am I showing you this? Because the diagnostic criteria by which we include patients in all the cardiogenic shock registries and databases, many of these patients will perfectly qualify and be included. Because rarely they have a Swan-Ganz catheter from the get-go, and we know their cardiac index in the absence of hypovolemia, which would be perfect inclusion criteria. But most of the time, especially cardiac arrest in the field, we go by a low MAP or low systolic blood pressure, and they would be admitted on vasopressin or norepinephrine drip, and we will consider them to be cardiogenic shock, although we don't really know what tried to kill them on the first time before they were resuscitated. So when we looked at Indiana University registry for cardiogenic shock, and we tried to go through the individual charts and to see in what context people experienced cardiac arrest, those who did. And we tried to separate those who clearly suffered cardiac arrest in the setting of either acute myocardial infarction or heart failure, and in whom we had either negative angiogram, no thrombotic events in the coronary arteries, and no history of low ejection fraction cardiomyopathy, but some chronic medical condition. That's what we saw. So this was our, again, Indiana University subset of cardiogenic shock, 180 patients. Among them, 80 had cardiac arrest, 100 did not. But when we separated them by individual chart review into causes of cardiac arrest, those who presumably had non-cardiovascular cardiac arrest contributed about 1/4 of this data set. And when we compared this subset side by side, we found very significant differences. For example, in those with clear-cut cardiovascular cause of cardiac arrest, mean ejection fraction was 26.6%. In those who did not have any cardiac cause explaining their cardiac arrest, but they had another severe disease, mean ejection fraction was 42%. And here is the question: should we stringent the criteria? Should we tighten them up for inclusion in the cardiogenic shock? If somebody has normal ejection fraction, is it true cardiogenic shock even if they had cardiac arrest? So this is the first point I want to make, and my first attempt to separate these two strands of the DNA. The second may be even more important. When we try to classify again our data set of cardiogenic shock with cardiac arrest, we separated them by one stratifier that is never employed in any known to me data sets or registries. It is anoxic brain injury. Anoxic brain injury carries huge mortality. That's what we got. So we had in the set of cardiogenic shock, we had 80 patients with cardiac arrest. 33% had anoxic brain injury, 66 did not. And this is the side-to-side comparison of this data set. Ejection fraction, no anoxic brain injury, 66%. Anoxic brain injury, 26%, 37%, much higher in anoxic brain injury. The wedge pressure, 37 millimeters of mercury in no anoxic brain injury, 15% or normal in anoxic brain injury. Mortality, so their cardiovascular status was clearly better than in those without anoxic brain injury, in favor of anoxic brain injury. But their mortality was sky high at 85% comparing to 51%. And I don't have to tell you that in anoxic brain injury, the mortality occurs not because of our skill in management of cardiogenic shock. Patients die when the family decides to withdraw the support. So it has nothing to do with our skill set or methods of management. It is purely neurological, social, ethical, legal, whatever you want to, terminology you want to use, outcome. So question again, in patients with anoxic brain injury, should they be blindly factored in the staging of cardiogenic shock, while the mechanism of death and the management they reflect is completely different from our cardiogenic shock? So basically, when we do not stratify cardiac arrest by this criteria, we are contributing to very high mortality subsets in our cardiogenic shock datasets and registries, specifically people who suffered non-cardiac arrests for non-cardiovascular causes, this one, and especially if we include people with anoxic brain injury, even if they had cardiac arrest because of myocardial infarction or congestive heart failure, doesn't matter. This is not what dominates their clinical picture. That's not what determines their outcomes. That's not what predisposes the outcome of the disease and timing of the outcome. So what I'm inviting you to think in the end of this doomed to fail, as David said, talk, is to think how we can better stratify the cardiogenic shock so that those who we include cardiac arrest, so that we include only those who are truly cardiogenic into our cardiogenic shock analysis.
David, could you join us back? David, could you just back to the podium? I have a question for both of you. We clearly hear that the severity of anoxic brain injury is a huge determinant. So you have a patient come into the ER, they've been down for 45 minutes, their pupils are fixed and dilated, unresponsive. I mean, I think most people would agree to be conservative, but in those patients that have return of cardiac function, they've had an out-of-hospital cardiac arrest, they're arousable. What about the etiology of that? It could be a proximal LAD widowmaker, young guy, VF arrest, resuscitated. It could be somebody with poor ventricular function and multivessel coronary disease. It could be something with acute fulminant myocarditis. And all of those seem to me would have different prognosis. So I think that we all agree that severe neurologic dysfunction, it's like something else, neuroprotective maybe, probably not. But in those that have some return of neurologic function, does it matter in terms of what the etiology of that arrest was?
I'm not sure I read any published studies on this. So basically the invitation is to stratify cardiac arrest in cardiogenic shock by etiology of cardiogenic shock, heart failure versus acute MI.
Right.
So I tried to compare this. I showed you our data set of 180 people. I tried to compare them and I didn't find major difference. So I started looking for other determinants of the outcomes, but I'm not familiar with any publications on this. Maybe David does.
No, I agree, Dr. O'Neill. It's a very good question. The issue is fundamentally, we're all faced with the decision support, not support. You have a 30-year-old person suddenly collapses. If you do nothing, the outcome is guaranteed, the body bag right away. Or you put them on ECMO and 50% of them will not leave the hospital vertical. So it's one of the biggest challenges to know what to do. We've all had the anecdotal cases of patients that are young that were comatose for a day or two and then made a good recovery. We just don't know.
Please.
The question is shock. So cardiac arrest is cardiac shock. There is lack of perfusion. So if you're debating about the question is mortality is worse on patients who had arrest versus non-arrest patients, yes. But the debate is, should it be included in cardiogenic shock? Yes, a person who's had a sudden cardiac death did not have perfusion. So by definition, that is shock. So I'll let the panelists open.
Yeah, I wonder if you guys have any question for our debaters. I would say they did a great job. Not as good as the first panel, but that's okay. We're not voting. Please.
Quick statement. And I agree, David and Maya, you're both right, in my opinion. Stratification for what? When you develop sky staging for what? So in my opinion, and I come from a pulmonary hypertension background, the WHO group classification was developed for therapeutic intent. I think we've got to start thinking about that in shock. It's really great to be able to say, well, if you have this classification, you're going to die sooner. You're going to tell a patient that? They may survive. I don't know if I would. It helps to talk to family about survival. But Ali and I have talked a lot about this, Banayosi. For what? So maybe the classification should be much more like what you said. If they're in shock at the time, if they remain in deep shock, if their microvasculature doesn't change into a better phenotype, because now I know a little bit about that, what happens? How should you treat them? That's my vote. But I love what you guys both said. I do.
Other comments?
I agree. I think cardiac arrest and shock go together. And what I always use the Sky paper in terms of classification of shock, and there's a nice bar graph that shows survival in each category with and without cardiac arrest. And I think including it in the classification is important for management, because I think we all see these patients, they're doing okay, and they're in B shock. But once they arrest, their mortality is 3 times higher, and I think that's where its importance is in understanding that outcome is significantly impacted once cardiac arrest happens. So cardiac arrest, while in shock, you lead to cardiac arrest. That's why it's really important to have it together, to understand that maybe we need to start trying to prevent cardiac arrest, because we know it affects outcomes significantly, and I think that's why it's important to always look at it together.
Always.
Please.
Classifications, I think it's important to also classify the cardiac arrests, right? There's a witness cardiac arrest that you get to very quickly. It's a reversible cause. Their potassium was low and you can shock them and they're out of it, versus the prolonged cardiac arrest or the out-of-hospital cardiac arrest. And I think there might need to be stages also for cardiac arrest.
I think...
We have one at the...
question? Yeah.
Question.
Can you hear me?
Yeah.
Okay.
Yep.
So Jane Farr, UT Southwestern. I just wanted to pick up on what Eddie just said about cardiogenic shock therapies for what. I think, Dr. Guglin, your point about anoxic brain injury and how that can divide these cohorts is critically important, because anytime we are faced with a patient with shock and we have to make a decision about this support or that, early or late. What we are explicitly, or probably more times implicitly saying, is where are we going? And not having a patient who's not waking up for whichever etiology is, it delays our thing, or delays, or we pause before we start to implement. And I think it's important for some of these shock studies, especially the CS study that came out of Prague. Of those 128 or so patients who early or late VA ECMO, if you actually look of where they went, none of those patients actually ended up getting a heart transplant, and only 3 of the entire cohort actually got a durable VAD. So the question is as soon as you implant ECMO, for example, whether it's immediately or 3 or 4 days later, the question is where are you going? Right. Because if you're saying that the only place you can go is recovery, well, then there should be no expectation that there should be really any major difference in outcomes, whether it's early or late or somewhere in between. So I think the for what question is the next important piece to always put on these trials. I'll stop there.
We've been wrestling with, for the Recover 4 study, we've been wrestling with how to deal with this. And what we decided in the trial is that if patients have out-of-hospital arrest or in-hospital arrest and are neurologic responsible, meaning that they can answer verbal commands, then we're going to include them in the trial. But probably more importantly than that, we've done this elaborate process called exemption from informed consent. So Recover 4 is going to have that built into the program in agreement with the FDA, with the University of Washington as being the core lab for teaching centers how to do that. So basically, the patients cannot provide informed consent. They can be included in the trial, and then retrospectively we can talk to the family or the patients after the start of the program. And I think we're going to get some more systematic data from the National Cardiogenic Shock Registry. We did exactly that. Patients were responsive and in shock. We took them to the cath lab, and we had a 70% survival. So I think, honestly, the whole etiology is important, but it all kind of comes down to the brain. You know, if we get good brain recovery, we're going to have a pretty good outcome. Thank you very much, and we'll go on.
Moving on.